Second, respiratory distress syndrome is caused by a deficiency of surfactant, the phospholipid mixture that reduces alveolar surface tension to keep the alveoli inflated and maintains alveolar stability. So a deficiency in surfactant prevents the infant from generating the increased inspiratory pressure needed to inflate alveolar units, resulting in the development of progressive and diffuse atelectasis. Diagnosis is based on the clinical picture of a preterm infant with the onset of progressive respiratory failure shortly after birth, in conjunction with a characteristic chest radiograph. Chest radiography usually shows low lung volume and the classic diffuse reticulogranular ground glass appearance, with air bronchograms resulting from alveolar atelectasis contrasting with aerated airways. Arterial blood gases usually show hypoxemia and hypercapnia. Respiratory distress syndrome also needs to be differentiated from transient tachypnea of the newborn. Now, respiratory distress syndrome is seen more often in preterm infants, unlike transient tachypnea of the newborn, which is usually seen in more mature infants. They also tend to have more severe respiratory distress that doesn't improve quickly, unlike those with transient tachypnea of the newborn. Regarding treatment, antenatal corticosteroid therapy should be administered to all pregnant individuals at 23 to 34 weeks of gestation who are at an increased risk of preterm delivery to prevent or decrease the severity of neonatal respiratory distress syndrome. In newborns without respiratory failure, nasal continuous positive airway pressure is the preferred initial intervention. If this fails and apnea develops, the infant requires endotracheal intubation and intratracheal surfactant therapy with poractin alpha, calfactin, or Baractin.